Well, it's probably the biggest bit of news coming out of the SFA in the last probably 10 years. For a lot of years, many of us who deal with peripheral vascular disease, claudicants and critical limb ischemia, patients have all been driven to try to improve the lives of our patients by some form of intervention. Now, those interventions have all had a recurrence rate because of restenosis been relatively high. So in the last 10 years, we've had the opportunity to have paclitaxel or drug-coated balloons become part of the standard of care in the United States. And the limitation was it limited restenosis, which was fantastic. The problem is there was a recent meta-analysis which focused on the mortality of the patients who were exposed to paclitaxel. And in this meta-analysis at years 3, 4, and 5, but particularly at year 5, there was a clear indication based on the meta-analysis that the number needed to harm was very, very low. It was about 14 patients. And that took us all by surprise. We have been so focused on patency rates, the durability of what we did, that we never really paid much attention, nor did the trials even suggest a risk of mortality. And so with this meta-analysis, it has increased the fervor of trying to figure this out. And so there's been a series of investigations, a lot of them driven by industry, many driven by investigators, and we've had a myriad of meetings basically around the world right now. We've had them in Europe and now in the United States, and then the FDA just concluded its own panel regarding this. And the challenge is that there seems to be a signal based on exposure to paclitaxel, but nobody, even FDA has agreed, nobody has shown the reason. There may be an association, but there's no cause and effect that is clear from a billionth of a gram exposure in your SFA or below your knee to the mortality rate of cardiovascular death. We just don't get the association there, even though there seems to be an association. So we've had this discussion at my institution and in my network, just as a matter of fact yesterday, based on the ruling. I've been very proactive, at least for my institution, that based on the original FDA letter that came out for this country back in January, or December, excuse me, at the time of the original manuscript, and then it came out with a much stronger, harsher letter in March. There have been a lot of missteps, both from industry as well as from how people have read the meta-analysis out of Greece. And so the FDA, in their most recent panel discussion, suggested that because the association is real, that further information is necessary. So they have backed away from actually suggesting a moratorium. They have said that there are patients that it still is beneficial to, the high-risk patient, for example, a long CTO or an in-stent restenosis patient or a critical limb patient where you want to get the longest durability for patency as to an outcome. But for my institution and for my patients, I think we have to take a step back, and without knowing the association or the causality here, I think we're falling back to a no-use policy, which is really striking when one thinks about that, because it takes you back to where you were probably about 8-10 years ago, which is trying to drive the best outcome for early benefit with the knowledge that patients will recur more often than without the drug-coated technologies. And so it's very, very challenging for our patients. And I think that the overall effect, unfortunately in this country, until we get better, sounder data, more clearer data, I should say, less murky, is that the benefit to your patients regarding durability cannot withstand the risk of mortality unless you know the cause and effect here. And until we know that, the safer approach is to probably put a moratorium, as we have, on their use.